Okay, hi, good night, everyone. I'm Regine Lavelle. I'll be presenting on spinal cord syndromes and spinal vascular disorders. Now, these are extensive topics, and so the topics will be split into two. Tonight, we'll talk about spinal cord syndromes. Of course, we start with the anatomy. So these two images show the internal morphology of the spinal cord. The first image on the left of the screen is the sagittal view of the spinal cord. So the spinal cord extends from the brainstem at the foramen magnum and terminates at L1, L2 vertebrae. Similar to the vertebral column, the spinal cord is divided into 5 regions, each having their own set of spinal nerves. So you have cervical T1 to 8, thoracic T1 to 12, L1 to 5, and S1 to S5. In addition, you have the coccygeal nerve, which originates from the terminal portion of the spinal cord, the medullary cone, and is the last and the smallest spinal nerve. Extending from the apex of the medullary cone, as you can see, is the filum terminale, which is a thin connective tissue structure, which is an extension of the pia mater, and it attaches to the sacrum and functions as an anchor to stabilize the distal portion of the spinal cord. Now, throughout the length of the spinal cord, there are 2 enlargements to accommodate innervation for the upper and lower limbs. So there's the cervical enlargement, C3 to T2, and the lumbosacral enlargement. On the cross section, you can see, again, the internal morphology of the spinal cord, and you can see the gray matter centrally and white matter, just like the rest of the central nervous system. Externally, there's a left and right anterolateral and posterolateral surface, which features a number of grooves and known as fissures and sulci. This slide just has an image showing the dentate ligaments, which separates the dorsal from the ventral nerve roots in the spinal nerves. We have another image here to get a closer view of the gray and white matter. So the gray matter of the spinal cord is the butterfly-shaped structure, which is functionally divided into the anterior, posterior, and lateral horns. At the center of the spinal cord is the central canal, which is filled with cerebrospinal fluid and is the most terminal part of the ventricular system. The gray matter, which surrounds the central canal, is composed of the anterior and posterior gray commissures that bridge the anterior and posterior horns of each half of the spinal cord. The white matter of the spinal cord occupies the space around the gray matter and is divided into the anterior, posterior, and lateral funiculi. The cervical and upper thoracic posterior funiculi are further subdivided into medial gracile fasciculus and lateral cuneate fasciculus. The tracts from the gracile fasciculus are responsible for transmitting conscious proprioception, fine touch, and vibration from the lower half of the body, whereas from the cuneate fasciculus, these transmit sensations from the upper half of the body. This image just shows the neurons of the posterior gray horn and how they are divided and the associated spinal laminae. So the white matter, this part is more related to the pathology that we will go into. So the white matter of the spinal cord is made of myelinated nerve fibers organized into ascending, descending, and intersegmental tracts. Ascending tracts are formed of primary afferent fibers, which enter through posterior roots of the spinal nerves and are divided into 3 distinct pathways: the anterolateral system, the posterior column medial lemniscus pathway, and the somatosensory pathways to the cerebellum. So in the anterolateral system, it includes the spinothalamic, spinoreticular, and spino-olivary tracts, which function to relay sensations of pain, temperature, and non-discriminative touch. The posterior column medial lemniscal pathway is formed by the gracile fasciculus and cuneate fasciculus, and those relay discriminative touch, vibration, pressure, and proprioception. Finally, there's the somatosensory pathways to the cerebellum, which are composed of the anterior, posterior, and rostral spinocerebellar tracts, which function to relay proprioception as well as sensations of pain and pressure. Now, the descending pathways are formed of efferent fibers that carry motor information from the brain or brainstem to the effector muscles. functionally divided into two groups. There's pyramidal, which is responsible for voluntary movements, and extrapyramidal, which is responsible for involuntary movements. The pyramidal tracts originate in the cerebral cortex and carry motor fibers to the brainstem and spinal cord. They include the anterior and lateral corticospinal tracts. The extrapyramidal tracts begin with the brainstem and carry motor fibers to the spinal cord. They include the tectospinal tracts, medial reticulospinal tract, vestibulospinal tract, lateral reticulospinal tract, and the rubrospinal tract. There's also the intersegmental tracts, which are short ascending and descending tracts that begin and end in the spinal cord, and they function to interconnect neurons at these different spinal segments. Those are important in intersegmental spinal reflexes. Now, this image basically just provides the summary of what we went through. It has a key to show the different tracts. So it's a cross-section of a typical spinal cord segment. It's important to note that the ascending and descending parts coexist on both sides, although this image has it split in the middle. Also very relevant to what we'll discuss are the dermatomes. And the dermatomes are areas of the body where sensation is subserved by a single nerve root. Peripheral nerves generally receive contributions from more than one dermatome. So lesions in peripheral nerves and lesions in nerve roots can be distinguished in part by the pattern of sensory loss. So in the image, you could see an anterior and posterior view schematically separated into sensory dermatomes, and centrally you have the peripheral sensory nerve distribution. And just to run through the dermatomes, the C2 is served by the back of the head and angle of the jaw is served by C2. C3 relates to the neck. C4, the front and back of the upper chest. C5 to T2, the upper limbs. T4, chest, which is delineated at the level of the nipples in men. T7, chest at the level of the lower ribs. T10, the abdomen, delineated at the level of the umbilicus. L1 serves the inguinal region. L2 to S2 serves the lower limbs. And S3 to 4 serve the external genitalia, as well as the buttocks in concentric rings. So these are some of the syndromes that we will discuss: central cord syndrome, anterior cord syndrome, Brown-Séquard, and posterior cord syndrome. As it relates to neurosurgery, spinal cord syndromes will be discussed in relation to spinal cord injury or trauma. As you probably already know, some spinal syndromes have non-surgical causes or contributors. And so we talk about spinal cord injury now. The most common cause of spinal cord injury remains motor vehicular accidents, falls, most common in the age group 45 years or older, particularly in older females with osteoporosis who have a propensity for vertebral fractures from falls associated with spinal cord injury. Third on the list is interpersonal violence, primarily GSWs, including in our setting. And then fourth on the list, we have sport-related injury, and the most common cause for sport-related injury, spinal cord injuries, would be diving. Other causes for spinal cord injury include vascular disorders, tumors, infections, spondylosis, iatrogenic injuries, vertebral fractures, and developmental disorders. It's important to note that 20% of patients with a major spine injury will also have a second spinal injury at another level, which may be non-contiguous. Injuries often associated with traumatic spinal cord injury also include bone fractures, loss of consciousness, and traumatic brain injury. And it's interesting to note that the rate of alcohol intoxication in individuals who sustain spinal cord injury is very high, 17 to 49%. Spinal stability is something to consider. Conceptual definition for this is the ability of the spine under physiologic loads to limit displacement so as to prevent injury or irritation of the spinal cord and nerve roots, and to prevent incapacitating deformity or pain due to structural changes. Then another description is the biomechanical. Continue.
Yep, go ahead.
Oh, okay.
You
Yes.
just froze for a while.
Oh, okay.
Oh.
So some define the level of a spinal cord injury as the lowest level of completely normal function. Therefore, patients would be termed a C5 quadriplegic even with minor C6 motor function, but most sources define the level as the most caudal segments of the spinal cord injury with motor function that is at least 3 out of 5 in power, and once pain and temperature sensation is present. So we discussed spinal shock previously in the cervical spine lectures, but it's considered in two senses. The first sense is caused by multiple factors: interruption of the sympathetics, which implies a spinal cord injury above T1. There's loss of vasoconstrictors leading to vasodilation and resulting in unopposed bradycardia. Loss of muscle tone due to skeletal muscle paralysis below the level of the injury, which results in venous pooling and thus hypovolemia. Or
Okay,
there could be
I'm just going to pause you here, right? These are two different terms. So you've got spinal shock, which is what you've got on the right, the transient loss of neurological function. However, the loss of sympathetic output is neurogenic shock. So neurogenic shock, you have the bradycardia and hypotension. So we just have to be very careful to separate those two.
okay.
Right? Okay, great.
All
So
right.
carry
Thank
on.
you.
Thank you.
And the level is usually above the level of T6, not T1.
Okay. Right. So we continue to completeness of the lesion. So we categorize it into complete and incomplete. The syndromes that we'll talk about fall under the category of incomplete spinal cord lesions. And a complete injury means that there's no nerve communication below the injury site, no muscle control, sensation, etc. Which results in quadri or paraplegia depending on the level of the injury, as is depicted in the small image on the right of the screen. So as I was saying, in a complete lesion, there's no preservation of any motor or sensory function more than 3 segments below the level of the injury. About 3% of patients with complete injuries on initial exam will develop some recovery within 24 hours. However, recovery is essentially 0 if the spinal cord injury remains complete beyond 72 hours. Bulbar cervical dissociation is something to pay attention to. It occurs as a result of spinal cord injury at or above C3. It produces immediate pulmonary and often cardiac arrest. Death results if CPR is not instituted within minutes, and patients are usually quadriplegic and ventilator dependent. And now we talk about the incomplete lesions, and they occur when there's any residual motor or sensory function more than 3 segments below the level of the injury. A couple of signs include sensation of voluntary movement in the lower extremities in the presence of a cervical or thoracic spinal cord injury, as well as sacral sparing, which is preserved sensation around the anus, voluntary rectal sphincter contraction, or voluntary toe flexion. Note well, an injury does not qualify as incomplete when there's only preserved sacral reflexes. And we'll start with central cord syndrome, which is the biggest of the 4 syndromes. And some key points is that in central cord syndrome, there's a disproportionately greater motor deficits in the upper extremities than lower. usually result from hyperextension injury in the presence of osteophytic spurs. And surgery is often employed for ongoing compression, usually on a non-emergency basis, except for rare cases of progressive deterioration. So as I mentioned, it's the most common type of incomplete spinal cord injury syndrome, seen as depicted in the image following acute hyperextension injury usually in an older patient with pre-existing acquired stenosis as a result of bony hypertrophy and the enfolding of redundant ligaments and flavum. Can also occur when there's translational movement of one vertebra on another. A blow to the upper face or forehead is often disclosed in history, or you can pick it up in exam if there are lacerations or abrasions to the face or forehead, often in relation to a motor vehicle accident or fall forward, often while intoxicated. It's also associated with sporting injuries, may be associated with acute traumatic cervical disc herniation, and may also occur in the presence of rheumatoid arthritis. This is just a short bit on the pathomechanics of central cord syndrome, and it occurs that there's a greater effect on the upper extremities due to the predominance of a large diameter motor axon subserving the upper extremities, along with the fact that motor function of the lower extremities can be conveyed via other motor tracts, including the rubrospinal and vestibulospinal tracts. So a patient who has central cord syndrome will present with weakness of the upper extremities with a lesser effect on the lower extremities. Varying degrees of disturbance, sensory disturbance below the level of the lesion may occur. Myelopathic findings, so sphincter dysfunction, it usually shows up as a patient with urinary retention. Hyperpathia, especially in the proximal portions of the upper extremities, which is often delayed in onset and very distressing. And Limity sign in 7% of cases, which is a paroxysmal pain syndrome, just used to describe the transient sensation of an electric shock extending from the spine to the extremities on flexion or movement of the neck. So the course of symptomology or the evolution of central cord syndrome, you'll find an initial phase of improvements, characteristics. Usually the lower extremities recover first, bladder function next, and the upper extremity strength then returns with finger movements being last. Sensory recovery has no pattern at all, and there may be a plateau phase following this, followed by late deterioration. Fortunately, 90% of those patients with central cord syndrome may walk with assistance in 5 days. However, recovery is usually incomplete, and it depends on the severity of the injury as well as the patient's age. Imaging, you may find on the C-spine X-rays congenital narrowing of AP diameter of the spinal canal, plus or minus osteophytic spurs, as well as traumatic fracture dislocation. The cervical CT scan is helpful in pinpointing or diagnosing those fractures and osteophytic spurs, but not as good as MRI for assessing the status of the discs, spinal cords, and nerves. The MRI, in addition, will disclose the compromise of the anterior spinal canal by those discs or osteophytes. And when combined with a plain C-spine X-ray or the CT, it increases the ability to differentiate osteophyte from traumatic disc herniation. Of course, we know MRI would be poor on its own in identifying fractures. And so key points in the treatment of patients with central cord syndrome, there's no rule for surgery if there's no ongoing compression or instability. Emergency surgery is indicated when there's documented progressive deterioration. In that case, the patient should be decompressed as soon as is possible. Early surgery is considered as in within 24 hours of the onset of the injury. and should be utilized when possible for spinal instability or patients with lung tract findings. Patients that are improving should be followed, and decompression can be done electively, usually within 2 to 3 weeks. This just goes into more detail of the surgical indications. So one would be continued compression of the spinal cord, 2, instability of the spine. Timing of the surgery, early is considered, again, within 24 hours. And the strongest indications for decompressive surgery in acute traumatic central cord syndrome include the rare patient who is improving and then suddenly deteriorates, and the additional presence of lung tract findings. Delayed surgery is indicated when there's significant persistent cord compression in patients who fail to progress after an initial period of improvement, and that can be done within 2 to 3 weeks without an arbitrary waiting period. Better results occur with decompression within the first few weeks or months as compared to waiting years. Now, the most rapid procedure utilized to decompress the cord is often a multi-level laminectomy. And where there's myelopathy, fused patients fare better than those who are decompressed without fusion. Central cord syndrome has a fair prognosis. Cord contusion without hematomyelia, approximately 50% of those patients will recover enough lower extremity strength and sensation to ambulate independently. Recovery of the upper extremity function is usually not good as is expected, and fine motor control is usually poor. Bowel and bladder control often recover, and with or without surgical treatments, only 41% over the age of 50 become ambulatory as compared to 97% of younger patients who will become ambulatory. Now, anterior cord syndrome is also known as anterior spinal artery syndrome. Occurs when there's cord infarction in the territory supplied by the anterior spinal artery. It may result from occlusion of the anterior spinal artery or from anterior cord compression, for example, by dislocated bone fragments or by traumatic herniated disc. So if there will be paraplegia, the patient could present with paraplegia, or if the injury is higher than C7, quadriplegia, and the sensory loss below the lesion is dissociated. So there's a loss of pain and temperature sensation due to injury of the spinothalamic tract, and preserved 2-point discrimination, joint position sense, and deep pressure sensation due to the intact posterior column function. So it's very important to differentiate a non-surgical condition, so anterior spinal artery occlusion, from a surgical one, for example, and when it's caused by an anterior bone fragment. So we need to utilize imaging, the gold standard of which would be the MRI. So MRI results can be negative in the first 24 hours, but it is still used to confirm the diagnosis. In addition, MRA or CTA, so angiography studies, are appropriate adjunctive modalities to delineate the vascular pathology. Surgical intervention is indicated for patients with evidence of cord compression. So for example, by a large central disc herniation, or in the case of spinal instability, whether it's ligamentous or bony. If the underlying cause is treatable, the promptness of treatment is the most important factor in the prognosis of anterior cord syndrome. And anterior cord syndrome actually has the worst prognosis of the incomplete lesions. Only 10 to 20% recover functional motor control. Sensation may return enough to help prevent injuries like decubitus ulcers. Next, we have Brown-Séquard syndrome. This is a hemisection of the spinal cord, and of course, the name was penned by Brown-Séquard, who discovered the injury or the lesion. Usually, it is a result of penetrating trauma, seen in 2 to 4% of traumatic spinal cord injuries. So the presentation of patients with Brown-Séquard syndrome is hardly ever in the pure sense or having the classical findings. However, these classical findings would be motor ipsilateral weakness below the lesion due to lateral corticospinal tract dysfunction, and there's dissociated sensory loss. So first, there's a contralateral loss of pain and temperature sensation inferior to the lesion, starting 1 to 2 levels below the lesion. There's ipsilateral loss of vibratory and joint position sense and touch and pressure, starting at the level of the lesion. And then there's contralateral loss of crew touch due to disruption of the anterior spinothalamic tract. Out of all the incomplete spinal cord lesions, Brown-Séquard has the best prognosis, with approximately 90% of patients regaining the ability to ambulate independently, as well as regaining anal and urinary sphincter control. The most rare of them all is the posterior cord syndrome. It's also known as contusio cervicalis posterior, pretty rare, and it usually produces pain and paresthesias, often with a burning quality in the neck, upper arms, and torso. There may be mild paresis of the upper extremities, but the lung tract findings are minimal. This table, it just summarizes all the spinal cord lesions that we went through. So we have the Brown-Séquard central cord with small lesion and large lesion, posterior cord syndrome, and anterior cord syndrome as well. And so we have to talk a little bit about the management of spinal cord injury in general, because as it relates to surgical practice, spinal cord syndromes is due to trauma. So the major causes of death in spinal cord injury are aspiration and shock. Of course, management begins with initial survey under ATLS protocol. So airway takes precedence, then breathing, then circulation and control of hemorrhage, followed by a brief neurologic exam. It's important to note that other injuries may be masked below the level of the spinal cord injury. And then any of these patients below should be treated as having a spinal cord injury until proven otherwise, and they include all victims of significant trauma, trauma patients with loss of consciousness, and minor trauma victims with complaints referable to the spine. So that would be neck or back pain or tenderness, as well as the spinal cord, which would be like numbness or tingling in an extremity, weakness, paralysis. Trauma patients would be triaged as such into groups 1, 2, and 3. Group 1 would be those with no history of significant trauma, who are completely alert, oriented, free of drug or alcohol intoxication, and no complaints referable to the spine. Most of these patients may be able to be clinically cleared without imaging. Group 2 includes significant trauma, but no strong evidence of spine or spinal cord injury. So the emphasis here is to rule out a bony lesion so as to prevent further injury. Group 3 includes patients with neurologic deficits. So the emphasis here is to define the skeletal injury and to take steps to prevent further cord injury and loss of function, as well as to minimize or reverse the present deficits. So we'll just run through stabilization and initial assessments. So there's immobilization, so you maintain backboard or head strap to facilitate patient movement, transfer, examination, and so on. And once those studies are completed, backboard must be removed to reduce chance of decubitus ulcers. And Then is hypotension or spinal shock. We need to maintain systolic blood pressures above or equal to 90 millimeters of mercury. Spinal cord injuries cause hypotension by a combination of factors, and that could worsen the patient's prognosis due to spinal cord hypoperfusion. Oxygenation, of course, trauma patients need supplemental oxygen. NG tube may be used to prevent aspiration, Foley catheter, so that we can, so we have ins and outs, and also to prevent urinary retention in patients. DVT prophylaxis, particularly mechanical prophylaxis, as well as temperature regulation, should be taken into consideration in initial assessments. And then we can do a more detailed neuro examination, and it was talked about previously, but the Asia impairment scale would be utilized at this point. So in the more detailed neurohistory, you need to ask key questions. So we want to know the mechanism of injury, hypoflexion, extension, axial loading, history of suggestive of loss of consciousness, history of weakness, occurrence of numbness or tingling at the time of injury. We also need to palpate the spine for point tenderness or step off, where you have the widened interspinous space. We get to do motor level assessments at this point. So skeletal muscle exam can help localize the dermatome, as well as rectal exam for voluntary anal sphincter contraction. Sensory level assessments, again, pin prick with, sorry. The hospital called me. Can you still see my slide?
Oh, no, it stopped sharing before.
Right. So we continue to where we are doing the more detailed neuro evaluation of the trauma patients. So in addition to motor and sensory assessments, I'm very sorry, the hospital keeps calling me. My phone is on Do Not Disturb and it's still ringing on all my devices. Okay, so in the neuro evaluation, we've gotten the focus history, examined for spinal point tenderness, did motor level and sensory level assessments. We also need to evaluate reflexes. So not just muscle stretch reflexes, but also the abdominal cutaneous reflex, cremasteric reflex, as well as the sacral reflexes. So that would include the bulbocavernosus and anal cutaneous reflex. And we should also examine for signs of autonomic dysfunction, so incontinence, sweat pattern, and examine for priapism. And this is just a copy of the printout that is utilized to do the Asia scoring in an efficient manner. So number 9 in the stabilization and initial assessment process is radiographic assessments. As we know and we discussed in prior classes, cervical color should be removed as soon as it can be determined that it is safe to do so, and methods are utilized at the Canadian C-spine rule and in Nexus criteria. If high quality CT imaging is not available, the goal should be 3-view cervical spine x-ray, so AP, lateral, and open mouth odontoid view. CT is the imaging of choice, especially for bony injury, and then MRI can be utilized if it is available and dependent on the agency. And this flowchart just runs through, is a flowchart on how to clear the rigid C-spine color for a patient. saw a little bit more on MRI. So it may be emergent if there's an incomplete spinal cord injury, if there's neurological deterioration, so worsening deficit or a rising level, and also if neurologic deficit is not explained by radiographic findings. And this includes if the evident fracture level is different from the level of deficit on exam, or if there's no bony injury identified on initial imaging. Non-emergent criteria include inconclusive cervical spine radiography, significant midline paraspinal tenderness in a patient unable to have flexion extension x-rays, as well as those patients that are obtunded or maybe comatose. And just to touch on it, there's a bit of information on medical management as it relates to spinal cord injury. So this is about methylprednisolone, which is not FDA approved for use in treating acute spinal cord injury because there's no class 1 or 2 evidence benefiting the support of its use. Class 3 data had been used to advocate its use, but it stated that the benefits were likely due to random chance or selection bias. Conversely, there's class 1, 2, and 3 level evidence that high-dose steroids are associated with harmful side effects and maybe even death. So as a result, use of high-dose methylprednisolone among spine surgeons has shown a steady decline. However, it was still used by as many as 56% of respondents in one survey. So early surgery for spinal cord compression, right? There's evidence or meta-analysis prospective multi-center spinal cord injury study with high-rated quality results show that surgical decompression within 24 hours of spinal cord injury was associated with improvement at 1 year in mean motor scores, light touch, and pinprick sensory scores, as well as Asia impairment scale grades. Also show that post-op changes in total motor scores decreased as time to decompression from injury increased during the first 24 to 36 hours, then plateaued after 24 to 36 hours following spinal cord injury. Caveats to this include that it doesn't take into account the functional ability or the quality of life of the patient. It only takes into account the scores or the grading scales. Also, the 24-hour cutoff for early surgery is arbitrary, and it is unknown if super early or ultra early, like less than 8 or 12 hours decompression would be even better. These studies also give no guidance as to what constitutes adequate decompression. So our question is expansile duroplasty helpful? And it is unknown whether it is beneficial in an Asia A injury. So surgery for those patients who don't require decompression but may have instability. So surgery for spinal instability due to the fractures or ligamentous compromise should be performed within 72 hours of injury when it is possible to permit earlier mobilization of the patient, which is associated with lower rates of cardiac, respiratory, and infectious complications. There's a caveat to this, which is unavoidable delays may be encountered for medically unstable patients, and then in some settings, the availability of equipment, techs, and so on. Right, and not going through this, but just want to mention cauda equina syndrome and conus medullaris syndrome, which we discussed previously, could also occur as a result, but as well as post-traumatic syringomyelia, which will be discussed in lectures to come. And so this is the end of part 1. That's the end of tonight. And next week I will be presenting on these spinal vascular disorders / malformations. And these are my references here. Thank you for listening. Sorry about all the delays.